Thank you. Hello again and good morning. Thank you guys for sticking around for my talk. I'm Josh Weis. I'm a general surgery resident at UT Southwestern. And my mentor, Dr. Scott, is past president of the Fellowship Council, so I've had the privilege of being involved in some Fellowship Council projects. I have no financial disclosures related to this presentation. So the Fellowship Council, if you were at my talk before, you saw this graph, is a non-ACGME organization that accredits surgical fellowships, and they offer 172 fellowships per year with 211 positions offered. And they have a variety of different types of training programs in sort of subspecialties like HPB, colorectal, or thoracic, and then some general specialties just like MIS or advanced GI or bariatric. And the FC also partners with national organizations like SAGES and the other ones you see here to develop the curricula for these different fellowships. And as I mentioned during the discussion of my last presentation, many of these organizations also offer certificates to their graduates. So we know what the criteria are for accreditation and the criteria to get a certificate from various organizations, but we don't know very much about what graduates do when they get out into practice. So the goal of this study was to gather some information on what these graduates actually go out and do. And so we did an online survey of 5 years of recent FC alumni, folks who graduated between 2013 and 2017. And we distributed it via email. We got email addresses either from program directors who were still in contact with their recent alumni and had their email address, or from the Fellowship Council archives, which was basically just the last known contact for the fellows. So not all of them may have been current, but we came up with the best ones that we could get. And the questions we asked are similar to the one you see there in the black box. So we asked in a 12-month period for them to estimate how many total, in this case, bariatric cases that they would perform with different approaches, laparoscopic, robotic, endoscopic, or open. And we classified them roughly into those ranges. So they did none, they did 1 to 10, 11 to 50, 51 to 100, or greater than 100. And we did this for bariatric, colorectal, inguinal hernia, ventral hernia, all different types of cases. And so for discussion of my results, I'm going to lump together laparoscopic, robotic, and endoscopic cases into MIS approaches as an umbrella category. And then you're going to see some graphs that talk about people that do some cases every year, and that means at least one. Moderate volume, which means greater than 10, and a high volume, which means greater than 50. We got 327 responses, which was 39% overall response rate, and this represented 512 different fellowship types. The reason those numbers are different is many Fellowship Council programs are dual accredited, so they are an MIS program and a bariatric program. So we double counted a few of our people to gather data on people who graduated from bariatric programs and also MIS programs. But if you were dual accredited, you got counted in both data sets. So these are the number of people who responded in each fellowship type. You can see the vast majority were the two most common fellowship types, advanced GI, MIS, and bariatric, but we got good response rates from HPV and a good handful from colorectal, thoracic, and advanced GI as well. So one of the things we asked was how often did these people use various approaches just overall for all of their cases in practice? And we were interested in MIS approaches. And you can see for some of the general fellowships, those first 4 columns, advanced GI, MIS, bariatric, flex endo, about 70 to 80% of the recent alumni said more than 3/4 of their cases were done minimally invasively, which we're very happy to see. Colorectal and thoracic even higher, 90 to 100% say they're doing 3/4 of their cases with MIS approaches. The outlier is HPB, not terribly surprising. MIS techniques are still finding their way in that specialty. So most of them are still doing most of their cases open. How much robotics is being used in practice? Again, 20% or so of graduates from those general specialties are doing 1/4 of their cases robotically, higher in the colorectal and thoracic groups, lower in the HPB. And then what percent of them are doing 1/4 of their practice as flexible endoscopy? Very similar trends as seen in the robotics category. So then we wanted to drill down a little bit on individual fellowship types and what kind of case types they were doing, not just approaches. So we're going to show a graph for each fellowship type. This is for just advanced GI alumni. We got 16 responses, and you can see to orient you to the graph, the white bars are people who do at least some cases in those categories. Gray bars are a moderate volume or greater than 10 per year, and black bars are a high volume. And these alumni sort of seem to have heterogeneous practices with some inguinal ventral hernias, foregut, colorectal cases, but they're not very high volume. There's no big black bars in any one category, so they're general surgery type practices. For MIS alumni, you start to see the black bars get a little bigger for some alumni, so about a quarter of them are high volume bariatric surgeons or do high volume MIS inguinal hernias, but still a good mix of cases, a lot of them reporting a moderate volume inguinal hernias, ventral hernias, and foregut cases in bariatrics. Not very many HPB or thoracic cases. For bariatric alumni, very similar graph to the MIS graph. A few more reporting high volume bariatric surgery, about 40%, but still moderate volumes of the hernias and the foregut cases, with about a quarter of them doing a moderate volume of colorectal cases. Again, not very many HPB or thoracic cases in practice. For HPB alumni, this is MIS cases, and you don't see very many large bars at all because most of their practice is open. So if you look at their open cases among HPB alumni, you see they tend to be a specialty type practice doing mostly HPB cases with some cases in other types, but not moderate or large volumes in any one category. And then colorectal alumni, again, a specialty type practice. They're doing mostly colorectal cases with a few hernia cases mixed in for some alumni. And similar for thoracic alumni, predominantly thoracic-based practices with some foregut cases, as you might expect, but really no other general surgery type cases mixed in there. So what's the impact of this data? I think this is great for prospective fellows to look at. We all go into fellowship because we want to get training in a certain thing and because we want to go out and practice and do that. And so I think this is encouraging that you can see people who do thoracic, HPB, and colorectal actually go out and get cases in those categories. And then people who are doing MIS and bariatrics are doing a lot of MIS cases across a lot of disciplines, which I think is what a lot of them hope to do. And then for the program directors and the national organizations, I think this is helpful as well. If you know what your graduates are going to go out and do in practice, you can design your fellowship to prepare them to do those things, which I think is the mission of most of our surgical educators. They don't just want to hit their numbers, they want their residents and fellows to go out and be good surgeons. And so now that we have more data about what their practices are like, we can develop curricula around that and make sure we're assessing competency appropriately in the relevant domains. So in conclusion, the Fellowship Council-trained surgeons perform impressive volumes of complex procedures, and minimally invasive approaches are very prevalent in these practices. Furthermore, many of the graduates carve out practices with big footprints in robotics and flexible endoscopy. Thank you, and I'm happy to take any questions.